but actually how that clot behaves. Because if you understand that, you may start getting less stressed about certain clots, or get less stressed about clots at different times in life. I'll talk about the problems with the clinical populations that have been used to inform our guidelines thus far. And then I'm going to talk about use of anticoagulants near the end of life, and then thromboprophylaxis in the hospice or specialist palliative care unit, and then tranexamic acid if we have time. So if I were to just, for those of you who are not familiar with haematology and thrombosis and hemostasis, if you were to put an electron microscope onto my brain, you would see that all the time I'm having microhemorrhages. And the reason I'm not progressing to a hemorrhagic stroke is because the coagulation system is immediately forming clots. But they don't stop there. If all I did was form clots in my brain and didn't remove them, my brain would be full of clot and the rest of my body would be full of clot very quickly. So we also have this hemostatic component in which plasmin, which are basically the scissors of the bloodstream, go around snipping at fibrin, and that will actually degrade the clot. So we'll come back to that, but I want you to understand these concepts now for when we look at data later. Now, a clot often will respond to damage of a blood vessel, and the first responders are the platelets, and then the erythrocytes come in, and then fibrin will form a mesh over it. So you know those times when people release balloons for charity? The balloons are the red blood cells. The net is the fibrin. Now, only recently, John Weisel's team in Pennsylvania have identified that if you look at this clot here, these, the platelets, play an intrinsic role in clot stabilization. So if you imagine your bag of balloons, the platelets, which are crisscrossing with the fibrin, contract and they pull on the fibrin, and it contracts the clot down and it helps stabilize it. So that's the first thing that happens, is your clot will adhere to the endothelial wall, it will contract, and then as it is stable, plasmin will come in and start snipping away. What they have also shown is in people with low platelet count, there is a higher proportion of patients who develop pulmonary emboli, which makes sense, because if your clot contraction is reduced in low platelets, which it is, you're going to have a less stable clot. And then at the other end, and I just want you to appreciate this, plasmin is there to break down clot. So it doesn't have a huge role in developing or making clot. It is there just to remove whatever clot is there. And when we give an anticoagulant, that does not dissolve the clot. It just stops the body making more clot and allows the fibrinolytic system to absorb things. And just as a rule of thumb, and I can give you the data where these came from, they're observational studies, but if you have your initial thrombotic insult, it usually takes 7 to 14 days for someone to have a clinically apparent DVT, and on average 21 days before they were to have a symptomatic pulmonary embolism. Now, there are exceptions, but that is the average. So, therefore, if you have someone who you believe has a week to live, I am less worried that their admission to the hospice or their deterioration is going to end up with a symptom burden from a clot. The other side of it is when someone has a clot and we panic that they're going to throw off a PE if we stop the anticoagulation. The initial stabilisation of the clot is probably about 14 days. 6 weeks is the time when we say we've got a stable clot, when we are comfortable to bridge a patient. So when I get rung by the gynecologists who have got a patient with an incidental PE and they want them to go to theatre immediately, and you say, well, let's have a look at the legs. Are the legs clear? There's some clot there. They need 6 weeks anticoagulation before it is safe to take them to theatre. Or that is one of the very few times I think a caval filter a retrievable cable filter is appropriate. So, just a brief overview there. Now, one of the problems is that the exclusion criteria for just about every randomised control trial regarding prophylaxis or treatment of clots, be it in cancer patients or non-cancer patients, have these exclusion criteria. So, poor performance status, prognosis less than 3 months, which is pretty much all the patients palliative care docs will look after. I mean, as an aside, I think we are incredibly poor at prognosticating. So, we often get that wrong. Weight less than 40 kilos or deranged biochemistry. These patients do not get into the clinical trials. And yet we're talking about our bread and butter patients. So we immediately know that the data we have, which informs the guidelines, were done in non-representative patient populations, and arguably the outcome measures were not appropriate either. You could have the biggest clot in your leg that you like, but if a patient nearing the end of life has no symptoms from it, I am less concerned. Because, you can find all sorts of hideous things radiologically, but it's what it means and what it does to the patient. 80% of people with PEs have no symptoms of the DVTs where the clot came from. So let's just talk about patients coming into the hospice. And there's a couple of observational studies. One was by my French colleagues who looked at 22 specialist palliative care units, just under 1,200 patients. And they looked through the notes, and 9.8%, just under 1 in 10 patients, had a clinically relevant bleed whilst an inpatient in the hospice. Now, definition of clinically relevant is a major bleed, so that's anything that kills you, requires transfusion, or a bleed into a critical organ, or a clinically relevant non-major bleed, which is any bleed which requires modification of anticoagulants or physician intervention. So we're talking about a large proportion of hospice patients are bleeding as inpatients. The majority of these patients, 91%, were cancer patients. Large, fair proportion were receiving chemotherapy. And if we look at multivariate analysis, we can see that the major things that determined if you were to have a bleed would either be a history of previous bleeding, because the person may have a coagulopathy, they may have a particularly vascular and hemorrhagic tumour. If they were on primary prophylaxis, so they were on an anticoagulant low dose, or if they were on antiplatelet therapy. So what that would be saying to me is these people are at high risk of bleeding, and it is made worse if you're on something which thins your blood. So I think nearer the end of life, we need to consider how necessary are these drugs. What we did was we reviewed what happens to palliative care patients, advanced cancer patients, if they are anticoagulated for an established DVT or PE. The international guidelines say that you should receive 6 months anticoagulation, and at 6 months, consideration should be given to indefinite anticoagulation if there is ongoing active cancer. So theoretically, palliative care patients are some of the most thrombotic there are. So when do you stop the anticoagulation? No one's told us when. There's no data to suggest when. The best we can do is look at what happens to these people who are fully anticoagulated. So we reviewed the first 450 patients that went through our specialist cancer-associated thrombosis service. That is the spread of patients we had. So a large number of colorectal, small number of brain, and then a fairly big mix, a large number of patients with breast cancer as well. At initial review, 44% had metastatic disease, 60% were receiving chemotherapy, and just under 60% were already known to palliative care services. And I think that's a reflection more on the complexity of their illnesses rather than prognosis. Now, of the 214 who died over 2 years, you can see that the majority died at home, and then just about equal numbers in the acute hospital and hospice. or community hospital, a small number. When we look at when anticoagulation was stopped, the majority continued it until the point of death. People were worried if they stopped it, they may have a large PE, they may have different or distressing symptoms. And what we found, actually, in the last 7 days, 7% had a clinically relevant bleed. What I'd point out was this was retrospective notes review because they died in many places, some in the community, some in the hospital. So we had quite a job of looking at their end-of-life notes. But these ones were actually recorded as having had a bleed. So what this is saying to me is that as people near the end of life, if you are anticoagulated, there is an increased risk, and I think a noticeable risk, of bleeding. And yet, we also know that in the last week of life, when we are looking to rationalise other medicines, arguably we should be doing the same with anticoagulants, because I believe the symptoms that they may develop could be managed with end-of-life medicines. So moving on quickly. Primary thromboprophylaxis. Should we be giving people prophylaxis? So the hidden study, patients admitted to specialist palliative care units had compression ultrasonography to look for signs of DVT, and it was attributed to whether they had any symptoms suggestive of VTE. The clinical team were blind to this. They had no knowledge of if a patient had a clot or not. Of just under 1,400 patients screened, 343 were recruited. I would point out that you there have just under 400 patients, about a third of the patients screened, who are being admitted for end-of-life care where thromboprophylaxis would not be appropriate. So we're already saying a third of our patients don't need to be anticoagulated, receive prophylaxis. Very poorly patients, Kanofsky of 49, survival 44 days in average. And what we found here was 34% had iliofemoral DVT on admission with very little symptom burden. And the only associations, I beg your pardon, was if they'd been bedbound in the previous 12 weeks or previous VTE. There was no difference between those who had clots and those who didn't in survival. So what we surmised here was that clots are very common in this population, but it doesn't cause any notable symptom burden, nor does it bring a premature end of life. So therefore, I would question in this specific cohort of patients whether or not primary prophylaxis is appropriate. How many minutes do I have left?
No problem.
Okay. Finally, how many times do we not want to give tranexamic acid to cancer patients because it's going to cause clots? Even in the British National Formula, it says it's contraindicated. So what is tranexamic acid? It's a synthetic lysine. And what it does is it adheres to plasminogen there, and by doing that, it blocks the plasmin from attaching to this string, stops it cutting it up. So that's what it does. It stops the breakdown of clot. It doesn't make new clot. It just stops whatever clot you've got there being degraded. So if you've been anticoagulated for some time, the clot is stable, and there is flow through the leg, for example, and that person has a bleed, yes, you can lower the anticoagulant dose, but you could also give tranexamic acid to decrease the bleeding. But isn't that going to cause a clot? It says so in the BNF. Well, let's look at a few studies, or I'll look at one main study. CRASH 2, patients who were involved in trauma, highly thrombotic, highly bleeding, were given tranexamic acid. Now, their survival improved for when they came to hospital to be managed. But what I thought was important here, when we look at the incidence of PE and DVT, there was no difference. And we are talking about over 10,000 patients in each arm. Now, I don't think we're going to get much better, more convincing data than that. Theoretically, it doesn't do it. In a large RCT, it didn't do it. In fact, MIs went down in those on tranexamic acid. So take-home messages. Number one, clots are cool. and you should embrace them and read everything there is to know about them. We know the trials we've got are from unrepresentative populations, so we need to be looking at our own patients. I think there's an ethical imperative that we do research in these groups. Consider stopping anticoagulants as death approaches, and consider not giving thromboprophylaxis in patients with very poor performance status or short thrombosis, short prognosis. Tranexamic acid does not increase thrombotic risk. Finally, can I pay tribute to my colleagues who undertook the hidden study? Miriam Johnson really pushed this forward and was absolutely key for the rigour of this, and Claire White, whose enthusiasm started it. So thank you for your time. I'm happy to answer questions if we have them.